Welcome, everybody. It's great to have you guys here today. So I'm Dr. Lauren Schumacher. I'm one of the CAP psychiatrists, and I'm very excited to have Dr. Michelle Riederer and Dr. Farah Virani here today to talk about pediatric depression in the primary care setting. So we'll start in a minute, just kind of letting people trickle in. And I'll tell you a little bit more about our speakers. So Dr. Michelle Riederer is a clinical assistant professor of child and adolescent psychiatry at UCSF. She's a CAP associate director for community outreach and engagement, and her clinical focus includes inpatient consultation liaison psychiatry at UCSF Benny Children's Hospitals in San Francisco and Oakland, as well as consultation to primary care and outpatient psychiatry. She completed her medical training at Icahn School of Medicine at Mount Sinai, adult psychiatry residency at New York University, and child and adolescent psychiatry fellowship at Stanford. Dr. Farah Virani is a clinical psychologist at UCSF Benny Hoff Children's Hospital, Oakland. Her primary role is with the Behavioral Emergency Response Team, conducting risk assessments for children and adolescents experiencing mental health crises. She also supports in providing brief interventions to medically complex patients in collaboration with the Psychiatry Consultation Liaison Service. She completed her doctoral degree at the Wright Institute in Berkeley, internship training with the Atlanta VA Medical Center, and postdoctoral residency at Jackson Memorial Hospital in Miami, with a focus on health psychology. She's passionate about working with underserved communities and aims to bring trauma-informed interventions and a systems theory framework to her clinical care. We're very excited to have you guys here today to share with us more on depression. And just before we dive in, we also wanted to announce we have a new Echo series that's starting soon. It's an Echo series on brief, effective tools and communication pearls for use at home, school, or in the clinic. This is going to be an interdisciplinary, collaborative learning experience that's really about kind of learning active skills and interventions to serve as a bridge for youth, teens, and families awaiting services for common behavioral health conditions like anxiety, depression, or ADHD. So this will include things like special time, behavioral activation, behavioral strategies you can kind of briefly share with patients during a short visit that can help them while awaiting getting into therapy. We've also sent out an announcement, so you can check your emails to register if you're interested, or you can see in the chat the registration information. I'll now turn it over to our speakers.
Thank you so much, Dr. Schumacher. I'm so pleased to be here today to talk about pediatric depression with you, and I'm very honored to be here with my colleague, Dr. Virani. And just before we get started, I need to share that I have no disclosures, no financial relationships or commercial interest to disclose, and that the UCSF CAP program is supported by federal and state grant funding, including funds from HRSA, as well as the California Department of Healthcare Services. So today we will be talking about depression in the primary care setting, and specifically talking about a couple of subjects related to depression, including, first of all, reviewing the epidemiology of pediatric depression and variations in presentation from a developmental perspective, and how depression can present differently in a younger child as well as an older adolescent. We'll talk about screening for depression and how to differentiate major depression from normal sadness, and sort of how to diagnose a clinically major depressive episode. And then we'll talk about the broad range of factors that can contribute to depression, including thinking about medical as well as psychiatric comorbidities, and talking about the formulation that we typically use in mental health called the biopsychosocial cultural formulation, and then talk about how to create a treatment plan for pediatric depression. including when to consider medications, talking a little bit more with Dr. Virani about psychotherapy and different supports that you can offer to teens and families, as well as when to consider consultation. We won't go too in-depth in terms of SSRIs. I will talk about medications briefly, but we have a whole separate webinar on treatment of depression with selective serotonin reuptake inhibitors. So stay tuned for that for more detail about the medications. First of all, I just wanted to start by reviewing depression and just how prevalent depression is, both, for our young people and, for everybody in the United States. And so it's very, very common. A lifetime prevalence for youth for depression is estimated to be about 11%, and about 7.5% of youth in the past year are estimated to have had depression. And, as children age, depression becomes more and more common. The prevalence increases with age, and that increase is much greater in females compared to males. What we also know about depression, in addition to how common it is that it is often underdiagnosed and undertreated. So it's estimated that only about a third of children and teens with depression are receiving specific treatment for major depression, whether that's therapy or medications, and about a third are receiving treatment from specialty mental health care. So that leaves 2/3 of youth who aren't getting treated for depression or are not getting specialty mental health care. And the reason that this is so important is because depression is a serious illness. 30% of youth with depression have reported some form of suicidality in the past year. 10% have reported a suicide attempt. And so we know that severe depression is a life-threatening illness, and that the best outcomes and the way that we can save lives is by recognizing and treating depression as soon as we can. One thing that I wanted to note is that the rates of depression have also been rising over the years. So data from 10 years between 2005 and 2014 have estimated that there has been an increased prevalence of depression, over the last decade. And it's really not super clear what is contributing to the rising rate of depression. It's thought that it could be related to more social cultural factors, whether that is the use of screens and phones and social media, or whether it's related to an increased awareness of mental health disorders and depression, an increased identification related to that increased awareness, or perhaps a combination of all of those factors. But the rates are rising, and I'm sure I'm preaching to the choir here. Teens and youth are presenting more and more with these challenges and with these symptoms, particularly after the last couple of years that we've had, which have been really hard with the pandemic for our young people. I wanted to touch on the natural history of depression. It's actually an episodic illness. So major depressive disorder is considered to be something that occurs in discrete episodes, and it often recurs. So if you've had an episode of depression, you are at increased risk for having a future episode of depression. Episodes usually are not, kind of long lasting and chronic for the rest of somebody's life. A discrete episode is estimated to be on average from 1 to 2 months to about 8 months. However, there can be a small percentage of young people who do experience a chronic form of major depression. And there are a couple of factors that put patients at risk for a more chronic form of depression. And some of those factors include comorbid other psychiatric diagnoses, such as anxiety, substance use, personality disorders. And there's also a relationship between chronicity, so the longer lasting episodes, and the increased risk for recurrence. And that's also associated with some other factors, including, a lot of stress or a history of trauma, family dysfunction, and some psychological factors such as negative cognitive styles, which Dr. Virani will talk a little bit more about psychotherapy and how that could be helpful. But just wanted to highlight that again, the natural history of major depression is that the episode should remit. However, it's likely in about, within a 5-year period, there's a 70% chance of recurrence. And so this can ultimately result in a very debilitating and challenging diagnosis for a child. So one of the goals for this presentation today was to highlight how depression can present differently for each person, as well as throughout the developmental phases. So depression can be a very heterogeneous disease. Young children don't necessarily always present with kind of the sadness or anhedonia that we think about with depression, but they can present in some different ways. So, for example, in a preschool child, what you might see is sort of absence of joyful play, just being a lot more apathetic or, kind of more reserved. In a school-age child, you might see more externalizing behaviors like irritability or having more tantrums or having really limited frustration tolerance. They might have some somatic complaints such as tummy ache, headache, or have more separation anxiety, not want to go to school, even complain of hallucinations. And then when kids then go to adolescence, they may present more with sort of what we think of as typical depression symptoms like endorsing sadness or suicidal thoughts, or having sort of more of the neurovegetative symptoms like increased sleep or eating more or less, or kind of being more sluggish or more reserved and spending time alone, isolating more. So in addition to sort of the different heterogeneous range of clinical presentations, we also know that depression can exist sort of along a spectrum. And so some children might present with more of a subsyndromal, milder range of symptoms, and others might experience much more severe symptoms and severe depression. And so this leads to the very important question: how do I know when someone is experiencing clinical depression versus everyday sadness or irritability? Because we know that it's normal to feel sadness. Every child, every young person has periods when they feel more sad, more irritable. That could be exaggerated based on the developmental stage that they're experiencing. For example, sometimes in adolescence with a lot of the identity issues and relationship issues, there might be more of that sort of questioning of the self and some more angst and sadness. And however, that does not necessarily mean that they're experiencing clinical depression. So what we really think about in terms of diagnosing major depression is, one, do they meet the DSM-5 criteria for diagnosis, which I'll talk about in a few moments. And then two, I think the most important factors are how much distress is the child feeling from the symptoms that they're experiencing, and then how much is their functional impairment in their situation. So the way that functional impairment occurs for children is in three domains. There's school. So how are they doing in terms of, they're meeting their expectations for school. There's their family, home life. How are things going at home with their parents, with their siblings? And then relationships. Are they, functioning socially pretty well, still making friends? Or, are they, really having a hard time with their peer relationships? So today, we're going to talk about screening, and then, after a positive screen, doing the evaluation for depression and then diagnosis. And then from there, the evaluation, we'll talk about treatment planning, including both pharmacological and non-pharmacological options for treatment of depression, and then following up. So a note about screening. I know that, over the years, there's been more and more of an awareness of the importance of screening for depression. And in fact, the USPS TF recommends that all young people between the ages of 12 to 18 be screened for major depression using the PHQ-9 screener. And I like to think of sort of the score cutoffs as, 5, 10, 15, 20, and 10 and above indicates a positive screen on the PHQ-9. That is usually significant for at least a moderate level of depression, with a 5 score as being sort of mild. Maybe you want to keep an eye on this, do some active monitoring, which we'll talk about in a few moments. And then as you're getting above 10, once you get to 15 and then 20, you have a moderately severe or severe case of depression. And then for younger children, if you have, a patient and they don't, they can't use the PHQ-9 because it's not validated for under age 12, then we recommend that you use the short mood and feelings questionnaire, which can be found on our website. And that can be helpful in eliciting sort of the degree of symptomatology, both from the child and the family. And then I wanted to note, of course, that screening doesn't equal diagnosis. So, of course, after you have the PHQ-9, can be really helpful in terms of telling you sort of getting a sense of what symptoms are occurring and how severe they are. But it's also really important to sort of do the evaluation for depression. And I just want to pass it to Dr. Virani to take it from here.
Thank you, Dr. Riederer. So once you do have a positive screen, some tips for evaluating further. If you are able to interview the patient and parent separately, this can be extremely useful. I think especially with our teen population, there are a lot of pieces of information that teens may be reluctant to share in front of parents for a variety of reasons. Some things we notice a lot here are teenagers worried about burdening their parents, especially if there are other stressors going on in the family. They really don't want to speak about their depression in front of their parents. They might be fearful about how their parents will react to them disclosing that they're feeling depressed. Sometimes teens are worried that they will be invalidated or shamed for feeling depressed and will be much more comfortable talking about this without their parents present. And it allows them to speak more freely about what stressors are going on in their lives, including if parents themselves are part of what is stressful, as well as any potential abuse that may be going on. And similarly, there may be things that parents feel more comfortable sharing without their child present. That may be like observations that parents have had about their teens or children that they have not yet shared with their teenagers. And parents might just not know that their kids are depressed, which is also really good information to have without the youth present. It's good to ask questions. Teens are sometimes unlikely to volunteer symptoms spontaneously, and using normalizing statements. Things like, this is a question I ask all my patients, or lots of kids your age are struggling with this. And to be quite honest, teens have become very savvy about mental health because of social media, and they might actually know that they're depressed and have language around that from peers or from social media. And so they already feel like it's maybe more normal these days to talk about it. If it is possible to get collateral from other adults in the patient's life, just to better understand how their functioning is at school, if they have a therapist already, how are they doing in therapy, what are things that have come up in those sessions, and including parents in the conversation with the teenagers and children if possible. It's not always safe to do so, but if you get the feeling from the youth that maybe they're just scared to tell their parents because they don't know how parents will react, but maybe it's not going to pose a safety concern, it can be really therapeutic to actually come together afterwards to just have that conversation, be the facilitator and explain to the parents what the youth is going through. And it can be a really great launching point for getting services, and can be really a huge intervention alone, just kind of bridging that communication between the youth and the parents. And obviously, if you're worried about any safety issues with the parents knowing, then that confidentiality can be maintained. And of course, if the youth is disclosing any kind of suicidal ideation, confidentiality would need to be broken in that situation. So another thing to pay attention to is just how is the patient presenting? And if this is someone that you've seen in your clinic a number of times, you have a good baseline on this patient, and mental status should always be considered in relation to the patient's baseline. So things that you might want to look out for: changes in eye contact, so patients making less eye contact, maybe being less talkative, looking more disheveled than usual. Maybe they're more irritable with you, or you notice that they're being more irritable with the parent in the room. If they are ruminating a lot or making negative self-statements, maybe they are just more distracted than usual, having a difficult time concentrating. It's also a good starting point for conversation. If the youth is having a hard time volunteering what information it is that they're feeling, you can make some observations saying like, I've noticed you're not as chatty as you are usually. What's going on? Or is this something you've noticed as well? Or maybe, you're expressing a lot of worries about school. I don't usually hear you talk about this. Like, can you tell me what's going on? And so, using your own observations to start the conversation can be really, really helpful, both with the parents and the child. So as Dr. Riederer was talking about earlier, we do have a tool, the DSM, for diagnosing major depression. This is what this slide is referring to here. This is the diagnostic criteria to diagnose major depressive disorder. So what it requires is the presence of 5 or more of the following symptoms during the same 2-week period, one of which must be depressed mood or loss of interest or pleasure. A good kind of mnemonic is SIGI caps with the D at the top and then SIGI caps that kind of goes through each symptom. It's a good way to remember it. So depressed mood, as mentioned earlier, this can look really different depending on the child, depending on the age. It can be a feeling that they disclose, or it might just be that their behavior has changed. Maybe they seem more irritable or they're more tearful than usual. A younger child may not always be able to describe what feeling depressed is like for them. It may be more observation by others. Certainly assessing for changes in sleep. So either sleeping more than usual or less than usual. And again, this is in comparison to the patient's baseline. Interest, so asking about activities that they maybe were engaged with the last time you saw them in clinic, and are they still doing that, or have they lost interest in those activities? And if so, why is that? Are they having any feelings of guilt or worthlessness? So we do see this actually a lot in our teenage clients, that they're feeling guilty about something, and it's not always something that actually happened. It's more just a feeling of burdensomeness or guilt that they are assuming someone might be upset with them because of how they're feeling depressed. They might be presenting with more fatigue or lethargy. And again, this goes into sleep changes, maybe taking more naps during the day, or it's more difficult to get out of bed. It can also show up as difficulty concentrating, and again, compared to baseline. So if this is a youth that at baseline might have ADHD or some other reason for having concentration troubles, it might be a different picture going on. But if typically they're able to focus in class and all of a sudden you notice that they're not able to pay attention in class, their grades are slipping, or they're seeming distractible during conversation, even during your visit, it's a good thing to pay attention to. Appetite, if there's any increase or decrease in appetite, and then psychomotor agitation or retardation. So asking the youth or the parents, do you feel like you're feeling more slowed down or moving more slowly than usual that other people have noticed, or moving more quickly, or you feel sped up like you're driven by a motor? Kind of giving examples like that, and also asking, like, is this something that you've noticed is different or something that other people have noticed is different? And then lastly, very importantly, is there any suicidal ideation? I know there's going to be another talk on this later, so we won't go too much into that, but certainly very important to assess for ideation, intent, plans, access to means, all of those things. And then, as mentioned before, we want to know, how much distress are these symptoms causing the patient, and how much functional impairment is this causing the patient? The other important thing to remember is that there can't have been a manic or hypomanic episode previously. So if the child has a history of mania or hypomania, we may be looking at something more like a bipolar diagnosis or something else.
So as we mentioned, the diagnosis of depression can often be a little bit challenging and heterogeneous because of a number of potential sort of other disorders that can look like depression, as well as the tendency for depression to also present with comorbid diagnoses, both psychiatric and medical. So just wanted to review that there's a number of medical conditions that can make patients look a little bit like they have depression, including if a patient has hypothyroidism, if they have mono, anemia, autoimmune diseases, chronic fatigue, migraine, epilepsy, asthma, IBD, as well as some cancers. And then some medications can also produce symptoms that look like depression or irritability, including some anti-epileptics, chemotherapy agents, immunosuppressants, birth control, steroids, as well as some other substances. And there can be even a substance-induced mood disorder. And then with psychiatric conditions, there's a variety of conditions that can cause irritability or low mood, such as PTSD, anxiety, ADHD. As Dr. Virani mentioned, bipolar disorder could also present with depression, or psychosis, autism, learning disorders, disruptive behavior disorders, all can cause some of that irritability or change in behavior that we see in depression. And so when you're doing an evaluation for depression, it's also important to consider whether there might be something else going on, including whether a different diagnosis might make more sense, or if there are other factors contributing. And I just wanted to highlight that comorbidities are very, very common in depression. So anywhere from 40 to 90% of youth with depression have a comorbid psychiatric disorder, and the most common ones being anxiety disorders, disruptive behaviors, ADHD, and substance use. And then anywhere from 10 to 30% of young people with depression also have a medical condition. And there's particularly strong associations with certain medical illnesses such as GI disease, autoimmune disease, endocrine disorders, and other neurological diseases. I wanted to talk about something that we call the biopsychosocial cultural model. And this is a tool that often psychiatrists and other mental health practitioners use when, meeting a child and kind of doing an evaluation and trying to understand what's going on. Because as we all know, everybody's experience of depression is different, and psychiatric illnesses are not so isolated and sort of, siloed in sort of this like biological way. We know that so many different factors can be at play in terms of, impacting a young person's mood and how they're navigating the world. And so we really think about all the different factors that are playing into a child's experience, and that might be contributing to depression. And so the biopsychosocial cultural model really talks about how biological factors such as, family history of depression, or, sort of like using the brain as a basis for depression, can interact with other things like psychological factors. So those are things like negative, cognitive styles, limited coping skills, poor self-esteem, different types of thought patterns, whether that's helpful or not helpful for the child. And then really thinking about that intersection with both the cultural aspects of the child's experience, what traditions, family values, beliefs, and stigmas occur for the child within their family and their community, and the social aspects. So, what's going on at school with peers, within the community, and even, in a greater sense, like what's going on in the country at the time. And I think there was a question, just talking about, asking about, ACEs and, early adverse childhood events and how that can impact depression. I think the biopsychosocial cultural model is an area in which we really want to think about all the different ways in which a child's experiences have influenced them and can be contributing to, depression or anxiety or whatever they're experiencing now. And certainly with, adverse events for a child, such as family stress, such as exposure to trauma, such as, lack of access to, stable housing or food or those types of things, medical illnesses, challenges with the family, all of those can contribute in this way, in these different ways, to the development of depression. And I also wanted to highlight there's something called the 4 Ps, which is a way of also thinking about the how a child develops depression. It sort of works well with this biopsychosocial model in terms of thinking about the factors contributing to depression, but the 4 Ps really highlights that there's predisposing factors. So for example, genetic factors, biological factors, in utero exposure to substances or toxins, and then precipitating factors such as stressors or recent trauma that really kind of tip the scales towards developing a depressive episode. And then there's perpetuating factors such as, ongoing challenges or, sort of psychological patterns for the patient that are prolonging the depressive episode, and then also encouraging one to consider the protective factors, the strengths of the family and the community and the patient, and what factors are really helping them to manage their depression or manage the stressors that they're experiencing. So after sort of, doing your screening, you've done your evaluation, you've talked to the family and patient, you've joined with them, explained what you think is going on. The next piece is to really think about the treatment planning, keeping in mind, all the different factors that are, maybe impacting the patient and the family and their community and what they might have access to. And so for treatment planning, we really think about, what's appropriate for the level of severity for their depression. In mild cases, so again, that's sort of like PHQ between 5 to 10 to 9, some psychoeducation ongoing and something called active monitoring, which we'll explain in a moment, might be appropriate. And then as you're getting to more moderate and severe levels of depression, then you're thinking about, of course, you're going to do that psychoeducation, but you may also make a referral to psychotherapy, and you're considering medication at that point. Dr. Virani, I'll pass it to you to talk about the next part.
Yeah, so for active monitoring, some ideas, obviously we want to give education to the patient and the family. Some of them might not have heard the word depression before, so giving some information about what is depression, what it can look like, and what parents and patients should pay attention to can be really helpful. I like to kind of cue patients and families to pay attention to things like changes in mood, behavior, sleep, and appetite. And so especially for younger kids who might not be tracking these things as well, making sure that parents have a good sense of like what to look out for in terms of monitoring whether this depression is worsening, staying the same, or maybe improving. I'll go into this in a little bit more about behavior activation, but this is something that can be really helpful for mild to moderate cases of depression, a form of psychotherapy, part of cognitive behavioral therapy. Sleep hygiene, there's some really good handouts on sleep hygiene. So sometimes just, making small changes to a sleep routine might improve sleep, which can have a really big impact on mood. Some teens are on their phones for a long time, like right up until bedtime, really poor sleep hygiene, especially with the use of smartphones and social media that are really on their phones until they go to bed. And so even making small changes to their sleep, like putting screens away 30 minutes before bedtime, can really improve sleep, which we know is a big contributor to mood. If there are any modifiable risk factors or stressors that are going on, that's a good place to start. That's not always possible. We have a lot of families who are in situations that cannot be changed very easily. But if you do have a patient who maybe is just really stressed out because they have too many pressures at school or too many pressures outside of school that can be minimized, it's a good idea to maybe just have that conversation about reducing some of those activities. Increasing peer interactions or just other like pro-social positive activities. This kind of goes along with behavioral activation, just giving the youth more experiences of joy, and continuing to do safety checks if there's any concern for safety. If there's any concern for self-harm, making sure parents are aware of what they can lock up or safety sweep at home, pills, sharps, things like that. Next slide. So I will talk a little bit about cognitive behavioral therapy, which is an extremely effective treatment for depression. It's evidence-based. It can be given in a brief model as well. So sometimes patients don't have access to long-term therapy, but can maybe get access to like 6 to 8 weeks of cognitive behavioral therapy for depression. So this really is a structured therapeutic approach that helps individuals recognize and change unhelpful thought patterns and behaviors, and kind of operates from the assumption that thoughts, feelings, and behaviors are constantly interacting and influencing one another. You can kind of see this little triangle in the background of the connection that kind of all work together and are bidirectional. It also kind of works under the assumption that how we interpret or think about a situation determines how we feel about it, which then determines how we react to it. And in the case of depression, it poses the idea that depressive thoughts such as hopelessness, helplessness, uselessness can actually intensify depression. And if we can help change those thoughts, it can help alleviate depression. Next slide. So there's kind of 3 main components to cognitive behavioral therapy. The C in CBT refers to cognitive restructuring. In this case, the therapist would help identify and challenge some of these negative thought patterns and help the youth replace them with a more balanced and realistic perspectives. That piece is best done with a therapist, a licensed mental health professional, but there are a couple of concepts that I think are pretty straightforward and could be introduced in the primary care setting. Behavioral activation being one of those things. And this is really just the idea that being inactive can cause a depression to worsen, and actually by engaging in more positive activities, this can increase mood. And then mindfulness is the other component to cognitive behavioral therapy. So just cultivating non-judgmental present moment awareness can just sort of slow down thoughts and promote a healthier response to negative thinking patterns. And I've included a couple of worksheets actually that are very simple and straightforward that physicians could potentially give to patients who are experiencing more mild to moderate levels of depression. A couple of behavioral activation worksheets. So both of them are really just having the youth identify enjoyable activities and or responsibilities. So maybe there's like, you know, basic hygiene things, showering, self-care, packing a lunch, just things that they're struggling with right now because they're depressed. Having the youth list these activities and then kind of rating them on a scale of 0 to 8 in terms of what their depression was before or after, how much pleasure they got from the activity, and what was their sense of achievement. And so if they're able to kind of implement some of these changes, it is likely to improve their mood. If they're able to do more during the day, both things that they feel they need to do and things that they want to do, it can have a really positive effect. The other one is just a weekly schedule. It's a little bit more straightforward, and just, you know, having the youth identify maybe 1 or 2 things to do each day that can increase their sense of motivation and accomplishment. And this mindfulness handout is very kid-friendly and teen-friendly. It kind of just goes over what is mindfulness, what are the benefits of mindfulness, and then a couple of different mindfulness practices. Maybe for younger kids, it's good to give this to the parents, but the 5 senses one is a really good one for all ages of kids. So kids who are maybe having really big emotional responses to things, this is really good to introduce to those youth to try in moments where they're maybe feeling really dysregulated, can't process, and a number of other ones. I know we're getting close to time here, so we'll be able to hopefully share those worksheets with you all to have. And then the two apps are both mindfulness apps, Calm and Headspace. They're both have free versions, I believe, are available on iPhones and Androids, and have a number of different meditations. Some are really simple and straightforward, some are more elaborate, but very appropriate for kids and teens as well.
Thank you, Dr. Virani. So those were some of the ways in which you could use, different worksheets, behavioral activation, CBT techniques, mindfulness, as well as referral to psychotherapy for a patient who is experiencing depression. I wanted to say a little bit about SSRIs, although there's another forthcoming webinar about that topic. Generally, these three SSRIs, fluoxetine, escitalopram, and sertraline, are the FDA-approved medications to use in children and teenagers. And the most evidence exists for Prozac. And so if you look at a variety of different, kind of algorithms, many of them will say start with Prozac as your first line for a young person who's experiencing depression. That being said, there's been some head-to-head trials where they've examined the efficacy of Prozac versus Lexapro and Zoloft, and there's no difference in saying that one particular SSRI works better than others. So you could either potentially start with Prozac or think about different different side effect profiles for the medications in terms of identifying which one to start with if you are starting a medication. Some things to highlight is that Prozac has a long half-life, so it could be helpful for a child or family that might be more prone to miss a couple of doses. They wouldn't experience any withdrawal symptoms if they do. However, it can be a little bit more activating. And so if you have a child with a lot of depression or they're already a little bit activated, you might want to steer clear of Prozac. For escitalopram or Lexapro, that is one that is particularly great if you have a child with other medical conditions or are on a number of other medications. It has the fewest drug-drug interactions. And I also personally like it because there's less of a titration schedule. The starting dose is 5, the max is 20, so you're not spending a lot of time adjusting the dose. And then sertraline can be slightly sedating, which is nice if you have somebody who is having sleep problems. You could give it at night, and that could be helpful in that way. And it has been studied extensively for anxiety disorders and is actually FDA approved for children for anxiety disorders, although it is effective for depression as well. And so it might be a great choice if you are working with a young person who's experiencing both depression and a lot of anxiety. In terms of the medications, one thing to definitely communicate with the family and with the patient is that there is a black box warning for the SSRIs for all youth under the age of 25. The black box warning states that there's an increased risk of suicidal thinking and behaviors with SSRI treatment in young people. However, what I always say is that, the risk of not treating depression is much higher in terms of experiencing suicidal thinking and behaviors than the risk of this particular side effect. And what we know is that, this black box warning came out a few decades ago, and right around the time that it came out, there was a precipitous decline in the using SSRIs. Everybody was scared off. And at that time, we also saw a much, very significant increase in suicidal thinking and suicide attempts and worsening depression. So the most important way to prevent or combat suicidal thinking and behaviors is really to treat depression. The other thing that you want to talk about is side effects of SSRIs. And what I always say is that there's some very common side effects, being usually GI symptoms, potentially some weight gain, sexual dysfunction, headaches, sleep changes. Some of these common side effects, such as headaches, sleep changes, and GI side effects are pretty transient. They usually start with when you begin the medication or when you change a dose, and usually they remit within a couple of days. So really encourage patients to stick it out, even if it's uncomfortable, because it's, really a sign. I kind of say that it shows us that the medication's getting into your body in a way it's working, because we know that there's serotonin receptors all over the body, especially in the gut, which is why the GI distress is such a common complaint. However, there are some side effects to be aware of that are more serious and may warrant, really reconsidering the medication or even stopping it. And so those more rare side effects include suicidal ideation, as you mentioned, with the black box warning. I think it's really important to get a good baseline of sort of what the patient is experiencing even before they start the medication, like how frequent are they having suicidal thoughts? What kind of, behaviors are they already experiencing before starting the medication, so that it's not suddenly attributed to the medication when it was occurring, before starting. And then if there's some concern about, a lot of activation or mania, depending on the severity of the symptoms, it may warrant at least, not further increasing the dose and potentially stopping the medication. Some other more rare side effects include platelet dysfunction. So SSRIs can interfere with platelet aggregation, so it might not be the right choice for any child who has a bleeding disorder. And then potentially it can cause hyponatremia as well. And then the most, one of the more severe and concerning potential side effects is serotonin syndrome, which is very rare, but the risk does increase if a child is taking multiple serotonergic agents. And so, to exercise caution. Usually this isn't the case for most of our young people, but if there's a history of migraines, if they're on triptans, that might be a concern. And then in terms of follow-up, ultimately I say as much follow-up as you can give and is feasible is really kind of the right amount of follow-up. But ideally, when you're first starting an SSRI, you'd be able to, at least check in via phone or telehealth if they're not able to come in person on a weekly basis. And then after the first month, then you can sort of stretch out the time of following up. In the second month, the recommendation is that it's kind of on a 2-week basis. And then the third month and onwards, it could be on a monthly basis. And then the titration, as you know, you're starting the medication at a relatively low dose usually, so that the patient can tolerate the side effects. But there will be a period of time where you're increasing the dose, and so sort of setting the expectation in the beginning with the family that, you're going to be increasing that medication to address the depressive symptoms, and that it might not work. They might not experience the effects right away, that it might take a couple of weeks, such as 4 to 6 weeks. And sometimes we hear this pretty often. Other people around the teen or the child notice differences before they notice differences, like more about how they're acting, or if they have more energy, or they're doing more things before the child themselves tells you, I feel better. And I see the time. So in order to wrap up, a couple of points that we just really wanted to emphasize is, one, how prevalent depression is in youth and how important universal screening is. And then two, that it's important to just ask and to talk about all the symptoms around depression, and to not be afraid to ask the questions. So ask about depressive symptoms, somatic symptoms, how they're functioning, whether or not they're experiencing current trauma symptoms or stressors, or if there's been a history of trauma or a lot of stressors in their life or their family life. And also to be mindful that a comorbidity is very common and very likely. And then when you're talking to the family and the patient, it's really important to join with them and educate them about, what you know about depression, and to normalize, to reduce the stigma, and to talk about together, the treatment plan, including psychotherapy, including medications if the depression is moderate to severe. And we're always available Monday to Friday during business hours to consult with you if you have questions for need assistance. And, we didn't talk about it this much, as Dr. Virani mentioned. We have an upcoming talk about SI and, sort of safety screening around suicidality. But I want to just emphasize that that's also very important when you're working with a depressed youth, not to be afraid to ask the questions, and to address that piece as well.
Great. Thank you both so much. So we have a couple of questions from the group. One is Dr. Grant's asking about advice around verbiage to use with a teen when they've disclosed depressive symptoms, have positive PHQ-9 and or self-injurious behaviors, but are not wanting to involve a parent or guardian.
Yeah, that's a great question, and I think it's one that a lot of you are going to come up against. I think really exploring why they don't want to involve the parent or guardian. First of all, as I mentioned before, sometimes it is a concern that the parent is going to respond poorly, which would have a negative effect on the teen and their depression. So if that is the case, if there's another trusted adult in their life that they would feel comfortable with us reaching out to, that can maybe monitor further and maybe bridge that communication with parents when it feels safe to do, or advise the child to maybe talk to the counselor at school, especially teens who are 12 and over, they can consent to their own therapy. So that might be a helpful thing to just share with them. Of course, if it's self-injurious behaviors and you feel like it is verging into becoming something more lethal, I think cutting is really, there's a wide range of cutting behaviors. If you do feel like the cutting or self-harming behavior is with suicidal intent, that might be a time where confidentiality has to be broken, and you would talk with the teen about that and explain why, and really emphasize that we want to keep you safe, and for that reason we do need to tell someone. That person does need to be your parent in order to keep you safe. If they're worried about a parent becoming abusive or harmful to them in some way, of course, involving Child Protective Services, and that does happen sometimes. But I think doing your best to understand why it is they're worried about involving the parent or guardian, and if you're able to bridge that communication and explain to them that this is to help them feel better, to help keep them safe, and to help get them access to resources that will help them feel better. I think emphasizing how positive it could be if you feel like it would be is a good starting point. But yeah, that is certainly going to happen. And I know that primary care visits are time limited. Sometimes you don't always have the time to really flesh these things out in session. But as best as you can, I think involving the parents can be really helpful. And even letting the parents know, like, hey, your child is a little bit worried to tell you this because of this, and here are some ways that might feel supportive to them when they share this with you. Here's some language for parents, like just validating the youth's feelings, not asking, why, or trying to problem solve, and just giving parents some tips around saying, I'm here for you, like I understand you're feeling depressed, let's get you some help, and giving parents some verbiage as well.
Yeah, I think that's really helpful. And it can be a process over time, that it may be, at the first appointment, they're not ready to bring the parents in, but you can kind of try to meet with them multiple times and have that be a goal that you work towards. And then I'd say the other place, so while they can consent to therapy, you do still need parents' consent to start psychiatric medications. So that's another time where you would need to, if the youth was interested in starting an antidepressant, you need to talk to them that the parents do need to be involved with that decision. And then another question that was asked was about the role of ACEs in pediatric depression.
Dr. Virani, I'm wondering if you'd like to speak a little bit to your work, as I know we see many youth in the Oakland the emergency department with a number of ACEs, but I think overall there's a tremendous link between pediatric ACEs and a couple of different chronic health conditions, including depression. And as I was saying before, it's really important to consider both past stressors and trauma and ongoing stressors and trauma when considering, your child and what's going on with them, because I think it's very relevant to the treatment plan that you're designing, both in terms of what they can access and what supports they have, and sort of factors to keep them safe.
Yeah, this can also be a good starting point for a conversation with the caregivers as well. Like, caregivers want to know why their kids are depressed, and sometimes bringing in the role of ACEs, and even from a research perspective and what we know about trauma and stressors, and even citing what those stressors are to the family. And certainly we do see the more ACEs a youth has, the more likely we are to see them present in our emergency department with major forms of depression, suicidal ideation, and more severe mental health issues. And so I think it's important to keep that in mind. And it's very well researched, and sometimes it's easier to digest for parents knowing that there's evidence as to why their child might be feeling a certain way.
And then another question we had is kind of, what are nutritional deficiencies that you kind of worry about or are associated with depression? And are there particular labs you recommend getting kind of when thinking through the differential for depression?
Yeah, I think on that list, there were quite a number, but the ones that are, coming to mind more in terms of nutrition are anemia, sometimes B12, and then other things like heavy metal toxicity, so checking lead. However, at least within the psychiatric community, we don't have a recommendation or guideline to routinely screen for those unless there's some, concern that a child might be, one, getting exposed to some toxin, or that, they're at risk for a nutritional deficiency based on history and, what they have access to. So purely from a psychiatric perspective, there's not really like a definitely rule out, this or this via lab, unless there's other indications based on your history and exam.